Welcome to Q&A with Prof. A, the Ibato kay Doc Bato educational series. The question thrown to us today is, Prof. A, how do we manage hyponatremia? Remember that hyponatremia is the serum sodium should be below 135 millimoles per liter. But caution that before managing hyponatremia, make sure that you're not dealing with pseudohyponatremia. Falsely low serum sodium can be due to high cholesterol, high sugar, or even from high BUN from kidney failure. Rule out these three causes first before proceeding to the management of hyponatremia. What are the must-know high-yield facts that we should know about in terms of hyponatremia? Number one, hyponatremia is water excess, and it is not directly related to sodium loss. What do I mean by that? If you have a 130 millimoles per liter serum sodium, that doesn't mean that I have lost around 5 millimoles of liter of sodium ions. Rather, I retained a significant amount of free water. So your serum sodium disorders are caused by water imbalances. Remember, water balance is regulated by the hormone vasopressin or ADH. In cases of abnormal serum osmolarity, antidiuretic hormone can be appropriately secreted or inappropriately released by non-pituitary cells, leading to excessively high levels of ADH. What is appropriately released ADH? It's always related to your low ECF volume. With low ECF volume, it will lead to the release of renin, and this release of renin will form your angiotensin II. Angiotensin II, therefore, then will activate antidiuretic hormone. With increased water intake, it will lead to your hyponatremia or low serum sodium levels. And how do we manage this? Remember, if it's with low ECF volume, correct it rapidly with your isotonic fluid boluses. This in turn will inhibit renin, and this renin will decrease the levels of angiotensin II, and now will also decrease the levels of antidiuretic hormone. With very low ADH, there's increased free water clearance, such that you have a very dilute urine. And the replacement is usually with either your half-normal saline solution, if it's available, or your oral rehydration solution, or ORS. This, in turn, will prevent your hyponatremia. Let me illustrate with a sample calculation of a 10-kilogram patient with diarrhea with a serum sodium of 130. So step 1, we replace with isotonic fluid boluses at 20 cc per kilo. Step 2, we calculate the sodium deficit not to exceed 10 mg per liter per day. It's usually desired minus actual times 0.6, which is your total body water, times the weight. In this case, we want it to be at 40. So the computed sodium deficit is around 60 mg of sodium. Now step 3. Step 3 is we compute for the total sodium requirement of this patient. That is your deficit plus your maintenance minus the boluses given. In this case, it's 60 plus 30, which is 3 mg per kilo per day, minus 20, we get our value of 70. And step 4, we choose the IVF that will best suit this sodium requirement. In this case, it is your half-normal saline to be given at more than maintenance rates, or if possible, ORS. Just a reminder, do not continuously give isotonic fluid in the setting of low-volume hyponatremia, like in dengue fever, especially in the rehydration or recovery phase. This will lead to acute rise in serum sodium. Now, what about this inappropriately secreting antidiuretic hormone cells? Okay, it is usually normovolemic, or they have a normal blood volume. However, these cells secrete an ADH-like substance, such that with increased water intake, it will lead to your hyponatremia. What are these ADH-secreting cells? They can be from your brain cells from meningitis, lung cells from pneumonia, cancer cells from solid tumors, or it can be anesthetic agents, or if your patient presents with pain, nausea, and vomiting, and even nicotine will release an ADH-like substance causing increased risk for developing hyponatremia. So how do we manage this? It's usually we decrease the water intake or restrict fluid intake of our patients, particularly hypotonic solutions or like water. It's so hard to do water restriction in reality because your thirst center will be activated if there's water limitation or if the water limitation will be too much. Therefore, the patient will drink more water. Certain drugs are given in these instances that will counteract your antidiuretic hormone. In cases when the patient is symptomatic or has dangerously low serum sodium of around 125 millimoles per liter, we give your hypertonic solution or your 3% sodium chloride. This will draw out the excess water due to the high sodium content, correcting the hyponatremia. Let me show you a sample calculation for a 10 kilogram patient with pneumonia with a serum sodium of 130. So step 1, we restrict fluid requirement to 80% maintenance. Note, you adjust for fever, tachypnea, or activity. Step 2, calculate a dose of hypertonic saline solution or your 3% sodium chloride. Do not use 0.9% normal saline. So using the computation, 10 times 0.6 times 10, we get a value of 60 mg of sodium. And step 3, we prepare the HTS solution by using ratio proportion, knowing that your 3% has 513 mg of sodium per liter. We get a value of 115 mg of hypertonic saline to be infused for an hour. So how do we prepare 1 liter of 3% sodium chloride? We remove 153 ml from a liter of plain NSS and add 7.5 2.5 millimoles per ml 20 cc vials. Summary: when you talk about correction of hyponatremia, always remember that it should be a slow correction of serum sodium, around 8 to 10 millimoles per liter per 24 hours. And it's not to overemphasize, treat the underlying disorder for all these cases. And to prevent the development of hyponatremia, it is prudent to start with isotonic fluids regardless of the etiology of your patient. And refrain from initiating very hypotonic fluids like water, D5-IMB, D5.3 sodium chloride, especially in patients with SIADH or syndrome of inappropriately high antidiuretic hormone. For more kidney concepts, don't forget to click the subscribe button.